Dr. Steve Feldman. Hey, Dr. Feldman, how are you doing today?
I'm doing great. Haven't gotten infected with the COVID yet.
Let's hope not. Um, are any of your patients affected so far? Do you know of, or
Not that I have heard.
okay, anybody close by, friends or family?
No, I should say nobody I know has gotten the infection. One of my former research fellows lives in New York, and she got the infection and recovered from it. Uh,
Welcome to Morgellons discussion and microscopy videos with your host, Jeremy Murphy.
Thank you for tuning in to Morgellons disease discussion and microscopy videos. I'm your host, Jeremy Murphy, and today we will discuss a variety of skin conditions with a dermatologist who was rated by Expertscape.com as the #1 expert in psoriasis and dermatology. He is the founder of doctor rating website www.doctorscore.com. Much of his research is on how well patients use their medication. He was also one of the stars in Skin Deep, The Battle Over Morgellons. Dr. Steve Feldman. Hey, Dr. Feldman, how are you doing today?
I'm doing great. Haven't gotten infected with the COVID yet.
Let's hope not. Are any of your patients affected so far? Do you know of, or
Not that I have heard.
okay, anybody close by, friends or family?
No, I should say nobody I know has gotten the infection. One of my former research fellows lives in New York, and she got the infection and recovered from it. They should use her as a frontline worker in the pulmonology ward now. But you asked if anybody's been affected. I don't know very many people who've gotten the disease, but everybody I know has been affected by it.
Wow. Yeah, that's a good perspective.
Shoot, I have this itch right now, right here, but I can't scratch it because of the
COVID.
Yeah.
Oh, yeah. What about the masks? Do you feel like those are a pretty good way to go, or safe bet?
The what?
The masks.
The mask. I can't see any reason not to wear a mask. So my wife and I went to the grocery store now, and we put masks on anytime we do outings, but mostly we're at home, and mostly we're doing a lot of hand washing. I do even more hand washing than I want to do because my wife makes me.
Well, she's looking out for you, obviously. Yeah. Why did you start a doctor rating website, and what's your experience been with it so far?
Oh, that's a great question. I originally went into medicine from the basic science side. I did chemistry, and as an undergraduate, chemistry, physics, and math, actually. And, I do really well on standardized tests. I was hired to do test tube research at a university primarily. They only let me see patients a half day a week.
Wow.
And they gave me Friday afternoon, of course. And then our psoriasis specialist, my partner, left, and the next day I became the expert on psoriasis. I didn't know what I was doing. And patients with psoriasis needed a lot of hand-holding because it was a chronic disease. There was no cures for it. And I'm like the worst person for hand-holding, right? Because I'm like a nerdy test tube scientist. I want to give people the right diagnoses, prescribe the right therapy. And so when I became a psoriasis specialist, I thought, this is great. I could walk into a room, throw the door open, stroll in. As I'm walking towards the person, look at them, know exactly what they needed for their psoriasis, write the prescriptions while I'm still walking towards them, hand them the prescriptions, tell them what to do, walk out thinking, I am a great dermatologist. I know exactly what they have, exactly what they need. And then our university started doing patient satisfaction surveys, and I got back these, feedback. Some patients said they liked me. Some patients said I wouldn't send my dog to that uncaring jerk.
Oh,
now,
man.
When I first saw that, my immediate thought was, they must have me confused with my partner, Alan. But then I realized, no, they talked about me because they couldn't tell how much I cared about them. They can tell is I walk in the room, throw a prescription on them, and walk out. And I I realized, gosh, this patient satisfaction information I'm getting is incredibly valuable to me.
Yeah.
But the way the university was collecting it was a nightmare. They had these stations set up in the hall of our clinic where there were privacy violations probably going on. And I thought, you know what? Using the internet might be a much better way to capture the information.
Oh.
I thought, I'll buy a list of all the doctors in America. Can make a website that connects that list to a survey that asks a bunch of questions. And I found a survey scientist who had a better way of doing it, where you ask just a few questions, but if there's a problem in any of the general areas, you drill down, get more information.
Right.
And then I put this out there for the whole world to see, thinking, number one, this would be a great way for doctors to get patient satisfaction feedback. I can do it. I can charge them a lot less than all the patient satisfaction companies charge because it's all done online. It's low cost. I'll be able to do research on the data I collect, and patients will be able to see how good doctors really are.
Huh.
Nobody knew how good doctors were. Even doctors had no idea how good other doctors were. I would ask doctors, doctors hated this idea of patient ratings because they thought patients would give them bad scores.
Oh.
I would ask doctors, what do you think the average score would be? And the doctors would say, on a scale of 0 to 10, the average patient will give you a score of 1 or 2, because only unhappy patients will give you ratings. And they're probably right that unhappy patients are more likely to give ratings. Your listeners, when they're listening to this and they're thinking, I'm going to get on the website, I'm going to go rate a bunch of doctors, they're probably thinking about the doctors they don't like to give the ratings to. So I think doctors are right. People are more likely to do the ratings when patients are unhappy. But what people don't realize is that the vast majority of people who see a doctor are happy with their visit. And doctors don't even know this because, I'm in the academic setting. I see patient after patient who comes from the private, the doctor, from the dermatologist in private practice. And not a single one of those patients was fully happy with the care they got. I see patients who saw family doctors for rashes. I can count on one hand the number of times I saw a patient for a rash that those family doctors managed to cure. And the reason for this is every time the family doctor sees a patient for a rash and makes the right diagnosis and prescribes the right therapy and gives and cures the patient, they don't send me that patient. I only see their failures. Every time the dermatologist in private practice makes a patient well, the patient isn't going to come see me.
Wow.
I only see the unhappy patients. And so it looks like, it's kind of like my understanding of Muslims. I'm Jewish. What do I know about Muslims? Well, right. if I based my understanding about Muslims based on what I read on the cover of the newspaper, I would think every Muslim is a terrorist because they don't print anything about the 1.5 billion Muslims who aren't terrorists.
Right. Right.
And so I had this database now of ratings, and it turns out the average score of a doctor who has 20 or more ratings is 9.5 out of 10. Patients love their doctors. I'm only a 9.3 out of 10, so I'm in the bottom half of doctors. Well, solidly down there in the bottom half in terms of my patient satisfaction. But 9.3, my mom sees the 9.3 and she goes, "Hey, my son, the doctor, his patients love him," but I could be doing better.
So, wow. And that's an interesting perspective. I hadn't really considered that it was actually your place in where the survey was coming in that almost guaranteed that you would get a low rating because these patients were being referred after not getting the objective met.
Yeah. So I feel bad for all the doctors who the only rating they have are from patients they referred to me, and I told them to go to this website and do ratings on me because I want the feedback. But they're also going to rate their other doctors, and they're never going to be happy with their other doctor. In fact, there's a doctor in Kentucky who was using this system for his practice. He paid us a small fee. He would tell his patients to do the ratings. We would send him these beautiful detailed reports. Everybody in his practice was practically either a 9.9 or a perfect 10. I mean, This is just a fabulous dermatology practice. Everybody loves these doctors. These doctors exude caring.
Yeah.
There's one other dermatologist in their small town, not in their practice. He has a terrible rating. And I don't think it's because he's a bad dermatologist. I think it's because the only people who rate him, the only people who know about the website in his town are the ones who are in the other office.
Poor guy.
Yeah.
Oh, man.
It's selection bias. I'm always looking for selection bias.
Yeah.
Selection bias has this enormous impact on people's perceptions of the world.
What is psoriasis? Can you define that for us? And what causes?
Yeah, psoriasis is my special area of expertise.
Yeah.
Psoriasis is a tough thing to define. Diabetes is an easy thing to define. It's when you don't have enough insulin action in your body. That's easy. Psoriasis, it's hard to define. Now, we know it when we see it. It's kind of like pornography, like what the Supreme Court said about pornography. We know it when we see it. Psoriasis has these red scaly patches. They have sharp edges. You'll see them on the elbows, in the scalp, ears, maybe less commonly on the face. They get on the knees, in the belly button, between the cheeks, in what we technically call the crack.
Yeah.
Can be on the palms and soles. It's an immune disease where the immune system is overactive. It's out of balance. It's making too much inflammation in the skin. It's making the same kind of inflammation that you get commonly with fungus infections like athlete's foot. But as far as we can tell, there's no fungus there. So it's the body making this immune reaction.
Gotcha. I have family members who have psoriasis, and it is a disfiguring condition itself. But definitely unique, and I believe identifiable if you're a professional.
Yeah. So yeah, you can learn to recognize it probably in a day. You could get really good at recognizing it. It doesn't take a genius to be a dermatologist, although you have to be a genius to become a dermatologist because it's one of the hardest fields to get into. We might talk more about that. Sure. But it's the golden age for psoriasis right now. If you turn on television, you'll see ads for psoriasis drugs. Most people with psoriasis just have a few spots and they can get by with some cortisone cream. The stuff over the counter may not be strong enough. We have stronger ones that work pretty well if patients use them. And that's another story we could get into. For people who have really horrible psoriasis, where it's like their whole body covered, well, those new drugs you see advertised on television are absolutely fabulous. And you may want to let your readers, your viewers know that I've probably taken money from every company that makes a product that you see advertised on television for psoriasis. Because, I consult for them. I give lectures on psoriasis all the time.
So how does treatment work? Does a patient see like a commercial for a psoriasis drug and they go, I got to ask Dr. Feldman about that? And are there any drugs that you would recommend over others?
Yeah, great question. I think the purpose of those ads is to get people to go to their doctor and ask about them. And if you're already seeing a dermatologist, hopefully your dermatologist would already be recommending those or some other treatment. You don't need, a lot of people with psoriasis could have bad psoriasis and don't need a biologic. They could start with ultraviolet light treatment.
Huh.
Ultraviolet light treatment is good for a lot of things that itch, including, and it's good for psoriasis. Ultraviolet light treatments calms down the skin's immune system and may have direct effects on itching too. Wow. I think when the Bible said, send the lepers out into the desert, and their leprosy goes away, I think they were really talking about psoriasis.
I got you.
So you can start with light treatments, maybe even just going to a tanning bed will make psoriasis better. But if you need a biologic, yeah, good to talk to your dermatologist about it. There's some older ones you still see ads for, like Enbrel and Humira. Those are good drugs. They're especially good for the joint pain that a lot of psoriasis patients get too.
Oh, wow.
But the newer drugs that block interleukin-17 and interleukin-23, which are key signaling molecules that cause psoriasis, I think they're more narrowly targeted to the inflammation that that you see in psoriasis than the drugs like Enbrel and Humira. And so I think they're more effective, incredibly effective, and safer. So safe now that if you had bad psoriasis and you were on one of these drugs, if you ask your dermatologist, I'm afraid of COVID infection, should I stop the drug? They'd probably tell you, they'd probably tell you, nah, don't bother. I would tell people, don't bother, stay on it.
Yeah.
Having your immune system out of whack because of your psoriasis may be more of a risk than being on these new targeted drugs.
That makes sense. Is there ever an instance where inflammation is a good thing?
Well, sure. Yeah. I think inflammation protects us from bacterial infections and other infections. We want to be able to make inflammation, and we want it perfectly regulated. We don't want too much and get psoriasis or other immune diseases, and we don't want too little and get infection and die. And the body is amazing that for most people, it's perfect or near perfect. We see a lot of patients who have various forms of immune diseases where the balance is off. In psoriasis, one of the things we worry about is that the inflammation of the psoriasis might also be inflaming your blood vessels and result in heart attacks and strokes and things like that. But you certainly don't want too little either. You want it to be just right.
Gotcha. Thank you for that perspective. So what about diet? Is there anything that we can eat or shouldn't eat that would make our skin look better?
I don't think so. I think a good healthy diet is terrific. Just a good general diet. What do I know about diet? If you go on a massive weight loss diet and you just don't have enough calories to turn on your basic functions, your psoriasis might get better because you can't make inflammation. You basically would be immune suppressed by dieting too much. A couple months later, your hair may start to fall out, being pushed out by new hairs because your body doesn't have enough energy to make hair, so it sends the hair into a resting phase. But a good general healthy diet, I think, is fine. Maybe there's some evidence that one of these Mediterranean diets has some marginal small benefit for reducing inflammation, although I think it's really tough to know. If you're thinking about, I want my skin to be better, what should I do? I would say wear a hat. Keep the sun off your face. Aging of the skin comes from the sun. Look at grandma or great grandma's underarm. It looks like a newborn baby, the skin there. It's just, all aging, I think, pretty much comes from the sun, what we think of as aging. And so you can do sunscreen if you want, but that's too much trouble for me. I just would wear a big hat and keep the sun off.
Yeah, no, the sun definitely is a problem. It's also kind of a conundrum because at the same time, it's the greatest source of UV light, which we could utilize for psoriasis inflammation.
Yeah.
What's the balance though? How much time should someone spend in the sun?
Oh, that's a great question. The standard dermatology answer is that people should not spend time in the sun. People should be active. They should go bowling. If they want to go out for a walk, they should do it at night. Now that's the standard dermatology answer. The dermatologist, if you ask them, well, what about vitamin D? They'll tell you to take a vitamin D pill. Don't do the sun. I think dermatologists may be a little overboard. Again, there's selection bias. What do dermatologists see all day? Skin cancers, melanomas. We think they're common because we see them. They're in our office all the time.
Oh, wow.
We don't see all the people without melanoma and without skin cancer. So it's not that big an issue. And I think there's some evidence that some degree of ultraviolet light is helpful, maybe helpful. Why did humans become lighter as they moved to more northern climates? Probably so they could get more UV light.
Yeah.
So UV makes us, some amount of light makes us feel good. I think ultraviolet light causes release of endorphins from the skin, feel good molecules. I think that's why some people are addicted to tanning, is from those feel good molecules. And I think it may lower blood pressure in some people. I think older folks who have joint pain, maybe those endorphins make your joint pain feel better. So most skin cancer occurs on the face, a fair amount on the hands. If you wear a big hat and keep the sun off your face, you could get a little sun on your arms. And I wonder if that's the appropriate, again, balance, where you prevent most of the skin cancers, but you still get some ultraviolet. Now, if you're Scotch Irish redhead with freckles, I would say stay out of the sun. Just stay out of the sun.
Yeah.
You don't want to burn. Burning is probably not helpful in the long run, probably increases risk of skin cancer. If you're Eastern European Jewish like me, or Italian, Middle Eastern, and you got some color, and you turn, you're probably not going to get skin cancer.
Gotcha. Okay. When you do have a patient who needs to be medicated, what is your experience on how well your patients are able to adhere to those protocols? And what is your research into this aspect of patient care?
Oh, that's a really great question. When I took over our psoriasis treatment center, the previous dermatologist, Michael Zanoli, who practices in Nashville, he's absolutely outstanding. He had set up this fabulous psoriasis treatment center. He had ultraviolet light boxes. He trained nurses how to, use them. He wrapped people in tar to get to the inflammation gone. When he left and I took over, dermatologists would still send me patients with horrific psoriasis. And I had no problem treating them because I could give them to the phototherapists and they would do the tar and the light and they knew how to fix people. But getting people with just spots on their elbow under control, or even worse, scalp psoriasis, I could not get them cleared up. Nothing worked. Well, I'm walking down the hall one day with one of my research colleagues, and he mentions there's a company in California that sells medicine bottle caps that contain computer chips that will record the day and time each time people open and close the bottles. These were designed, I think, to study how well people took drugs for AIDS. For HIV infection, the original drug treatment regimens involved taking medicine like 5 times a day. Now it's like a pill once a day. It's great. But then it was really difficult to take these pills 5 times a day. Doctors want to know, are people doing it? So they invented these caps. When my research colleague told me about them, I was like, they make what? And I turned to my minions and I said, I don't care what they cost. We have to find out what my patients are doing. So we happened to be doing a study in psoriasis with a cream for the elbows and knees. And we gave it to people with the computer chips on top. And we were honest with the people. We told people, we're going to monitor your use of the medicine. So fill out this daily diary and bring the bottles back for us to weigh. So you can see we were honest with them. We told them we were monitoring them. But we didn't mention the computer chips. Some patients came back with diaries that said, I use the medicine every day, twice a day, perfectly. Some of those diaries, they used the same pen for every one of those days, like as though it had been filled out all at once. And the computer chips said those patients almost never opened the bottles. Other patients used the medicine pretty well the first day. Pretty much everybody used it the first day. But the use of the medicine goes down very steadily over time.
For everybody.
In fact, we did one study where we followed people for a year for their psoriasis with a topical anti-inflammatory that they were supposed to put on twice a day. And the title of the paper was something like long-term adherence to treatment is abysmal. Because it was so bad. The reviewers, the scientists said, yeah, abysmal, that's the right word, because it goes in the first month or so, it goes down. And then over time, it just keeps going. It's just terrible. And so my whole approach changed. Now, if you look at the medical literature for why people aren't taking their medicines, because we know people don't take their pills, but they're even worse about putting their creams. The medical literature talks about the cost, forgetfulness, that the patient can't afford it, the patient is forgetful, the patient is lazy, the patient doesn't know what to do, the patient isn't well educated, the patient is not motivated. It's like 20 different ways of blaming the patient. And a dermatologist once shared with me this wisdom by a Vietnamese Buddhist philosopher whose name I cannot pronounce, who said something like, when the lettuce is not growing well, you don't blame the lettuce. You can give it more light, more fertilizer, water it more or less, but you don't blame the lettuce. And here, not just dermatologists, but medicine in general was blaming, I think, patients for what was really the doctor's fault. The doctor needs to make the right diagnosis, prescribe the right therapy, and get patients to use the medicine. And they weren't doing it. I mean, they taught us to make the right diagnosis. They taught us to prescribe the right medicine. They taught us nothing about getting people to use the medicine. And I like to explain it to physicians. I use the parable of the piano teacher. My kids took piano lessons. The piano teacher gave them some sheet music and had a lesson with the child once a week. And at the end of 8 to 12 weeks, there was a recital. And the recital sounded great because my kids were practicing every week. If a new piano teacher came out of piano teacher school and said, that's a very inefficient process. The reason they sound good at the recital is because they're practicing, not because of the weekly lessons. I'm going to give them the sheet music, tell them to practice every day, not have weekly lessons with them, just see them back at the recital in 8 to 12 weeks. How do you think that recital would sound, Jeremy?
Great analogy. Great analogy.
It would be abysmal. It would be execrable, And doctors aren't exactly like that piano teacher. Doctors are worse, a lot worse. Doctors are like a piano teacher who says, here is a prescription for some sheet music. Or maybe here's a prescription for 6 different forms of sheet music. I want you to fill all 6 of these. I have no idea what it's going to cost you. I want you to practice every day. I want you to take them every day, practice every day. Practicing may cause rashes, diarrhea, maybe even a serious infection, but I want you to practice every day. I will see you back in 2 to 3 months. And if the recital doesn't sound good, we'll switch to a new musical instrument. And we're scratching our heads. Why aren't patients taking the medicine? It makes no sense what we're doing as physicians.
So how do you circumvent that?
Hold on. Somehow my cell phone just popped on for no good reason in my pocket. Sorry about that.
That's okay, my friend. How do you circumvent that effect, though, and get your patients to start taking medications?
Okay. There's a lot of things I do. Okay. They're all designed to help my patients. Well, to start, I try to keep the treatment simple. And I try to make it seem even simpler than it is. For example, if I want mom to put a medicine on her child twice a day, I may tell mom, we're going to have you use this medicine 4 times a day. Before school, have the school nurse do it at school, do it after school, and then again at bedtime. No, wait a minute. That's a lot. Let's just do it twice a day. If I start by telling mom twice a day, she's thinking, I got to chase that kid down twice a day.
Yep.
If I start by saying 4 times a day, she's thinking, I got to make an appointment to talk to the school nurse about this. Oh my God, what a hassle. I have to miss work. I'm going to need a second container of medicine. And then when I say, no, wait, let's just do it twice a day, she's like, oh, what a relief. Just twice a day. So I make it simple. Try to keep it down to 1 treatment if possible. I make sure it's affordable. If you're not familiar with goodrx.com, get familiar with it.
Great.
I try to prescribe generic medications that are low cost whenever that's an option. But the most important thing I do is that piano lesson, that sense of accountability. And the way I get there is I'll tell patients, let's start on this medicine, and I'll see you back in 1 week. No, wait a minute. Then you're going to have another copay and have to miss work. I tell you what, here's my cell phone number. You call me in 1 week and report the progress. It doesn't matter whether I answer the phone when they call or not, because that doesn't change what they did. But if they are expecting to talk to me in 1 week, it has a dramatic effect because they feel like I got to fill the medicine. I got to use it because I'm going to be talking to him next week. Or if it's for something like scalp psoriasis, which is extraordinarily resistant to treatment because people have trouble doing it, I tell them it's just 3 days. You call me in 3 days.
Oh.
And they call me and they're like, you're right. It's like a miracle. The stuff the previous dermatologist recommended that didn't work works like this if you can get people to do it well, which is really difficult to do because we're human. And I mean, my gerontologist put me on a statin. Do I take it? No, I don't take it.
But you've got you're injecting the human experience back into medicine where, the patients aren't going in alone. They've got you right next to them and they get to touch base with you in about a week or 3 days.
Yeah. A lot of this comes together. What did I learn from the doctor rating website? What determined patient satisfaction was not how old the patient was. It was not their race or sex. It wasn't how long you kept them waiting. It wasn't how much time you spent with them. Basically, the only thing that determined patient satisfaction was whether the patient thought you cared about them or not.
Yeah.
And so here I am. I care about my patients, but I'm one of those men from Mars kind of guys who I care about people. I want to get them well, but I don't want to listen to stories, and I don't need to know what the kids are doing. I'm like a nerdy test tube scientist, and that's not what patients want. And so I have to pretend to be, one of these warm, caring, empathetic physicians. To make people realize how much I do care about them.
Yeah. Well, I mean, you can't make up actually being present.
That's a really interesting point. Can you or can't you? I'm willing to wonder about that. I gave a talk I was invited to speak to the Dermanities Society meeting. This is the Society of Dermatology Humanists. They're the opposite of me. They are not the people who got into medicine because they do well on standardized tests. They enjoy talking to other people. I'm basically autistic. And I got there early so I could see what their meetings are like. And they're like reading poetry to each other and stuff. And I'm more comfortable with test tubes. So I gave my talk on how you get people to use their medicines. And they're like, Steve, you can't fake empathy. And I'm like, what do you mean? If I go through and do the motions of what you do naturally, how do people know the difference? I mean, if these empathetic physicians naturally are comfortable putting your hand on people's shoulder and touching them and reaching out and communicating with them, if I do that, if I go through the motions of putting my hand on the shoulder and looking at them in the eye and telling them, listen, I want to know how this is doing. Call me in 1 week and let me know.
Yeah.
I don't know if that you can tell the difference or not. It's such a fascinating area. Do our politicians care about us, or are they going through the motions? What do you think?
Well, I mean, they definitely don't have to be there. And a lot of them take a lot of flack for going in there and sitting down and debating for their constituents. So
yeah, I have the impression that people are good and that they do care. They don't always leave you the impression that they care, but I think they do.
Yeah, if you didn't care, I guess the question is, would you still do it?
Would you still do what?
Whatever you're passionate about.
Yes, fair enough. I think you're absolutely right. I think to some extent doctors may think we have somewhat of a monopoly on being the compassionate people in the healthcare system. And the pharmaceutical companies, I think I never actually made anybody's life better. The only thing I did was prescribe the drugs from the drug company. The drug company made the drug that makes people's lives better. I think they really take pride in the fact that they are making this enormous investment in bringing drugs to market, and that they care about people and want people to get well. The insurers that I've talked to, they go to bed at night, they sleep very well thinking, I do my best to try to get access for people to get great medical care. And I wouldn't have a problem doing it if it weren't for greedy doctors and drug companies. Everybody thinks other people are not the compassionate ones. I have a lot of faith in people.
Yeah, I as well. I don't think anybody's out to be malicious on the whole.
Yeah, well said.
What about zits? Should I pop it or come to see you about it?
That's a great question. So I would not pop it. I think popping causes more scarring. But I don't necessarily think you have to come to a dermatologist. You can. It's great. We have to, especially if you've got bad scarring acne, you catch it early. Let us put you on some good stuff that will cure it. But if you have relatively mild acne, there's some really great over-the-counter things you can start with that are what we would prescribe, basically. Over-the-counter benzoyl peroxide products will kill all the bacteria that cause acne.
Oh.
Now they can bleach stuff. You have a cool t-shirt on. If you put the stuff on and then pull that t-shirt over, you'll end up with little white spots around the collar. So I want to caution people not to, to be wary of the bleaching effect of peroxide, of the benzoyl peroxide product.
Oh, gotcha.
A patient taught me to be especially cognizant of this. A mom said she brought her 2 teenage boys to see me for acne, and I was treating them. And I mentioned this bleaching effect, and she said, oh yeah, the previous dermatologist prescribed that stuff to my boys and didn't tell us about the bleaching side effect.
Gotcha.
And the boys wrestled on the living room carpet.
Oh, no.
And so I'm really careful. So the benzoyl peroxide product is great, but my son used it, and he ended up with white spots on his clothes.
Yeah.
The other product over the counter is adapalene or Differin. It's a topical retinoid, great for the whiteheads and blackheads. So if you're on the relatively mild acne side, use benzoyl peroxide and some Differin. Use one in the morning, the other at night. And do use it. Come up with a system that reminds you to use it regularly. Those are great treatments. And I can email you those later to share with your viewers if you like.
Yes. Yeah, please, definitely.
But then beyond that, we have oral antibiotics that are if you come to the dermatologist, we prescribe oral antibiotics. If you're female, birth control pills are a very effective therapy. Then there's the isotretinoin, which you take by mouth for 4 or 5 months, and it cures horrific acne.
Wow.
But it's also a powerful teratogen. It causes birth defects if you get pregnant while it's in your body. So we're treating teenage girls with it. We have to be extremely careful with this stuff. Now, Jeremy, I've probably said some crazy things already, but I don't want to lose my credibility with your audience. But teenagers with acne aren't always using their topical acne medicines 100% of the time like we recommend it to them.
Wonder why.
Well, it's all, for one reason, dermatologists are saying, put this on every day. I'll see you in 8 to 12 weeks. That's part of why.
Yeah, that's a long time.
Another reason why teenagers don't do it is because their parents are telling them to do it.
Huh.
I don't know if you realize this, but people don't like to be told what to do, especially teenagers. And, if mom is telling the teenager, don't forget, put the acne medicine on, the teenager's like, no, I'm not doing it. You can't make me, You would think people would grow out of this, but, I used to travel a lot before COVID for work, and I'd come home and the trash can would be full. I'd reach to take out the trash. If I heard my wife yell, don't forget to take out the trash, I'd be like, I'm not doing it. She can't make me. There's a lot that goes into compliance with medicine. It's a lot of human behavior, which, intrigues me as this autistic, scientist dermatologist, that I have to be so focused on this.
Wow. That's, the trash got me. taking out the trash. What about varicose veins? Do we have anything effective for those?
Yeah. Varicose veins. So these normally you have valves in the veins of your legs. They're pointed this way.
Huh.
So when the muscles squeeze the veins, the blood gets pumped upwards. So basically, your calf muscles are like hearts, pumping fluid out of your legs. Gravity's pulling it down, and the muscles push it back up. And humans, we tend to just sit there, right?
Yeah.
And so the fluid collects in the legs, and the veins these valves tend to go bad. And when that happens, there's this massive pressure, and then you get pressure and blood backing up into the smaller veins, causing these varicosities to form. Vein experts might be able to do something for those valves and things to the deeper vessels, but the simple thing is to see a dermatologist or maybe plastic surgeon or a vein specialist who can go in, squirt stuff into the dilated vessels and make them scar down and destroy them. So it would be a cosmetic way to treat them.
Okay. So it's like a simple injection and then they just disappear.
Yeah, you inject basically like a high strength salt solution into the vessel that destroys the vessel wall. The vessel scars down and disappears.
Wow. Here's something interesting I ran across doing research when putting our list of questions together. Keratosis Pilaris. Am I pronouncing that right?
Keratosis Pilaris, yes.
What is this? Is this a common skin condition?
It's a very common skin condition. Keratosis pilaris is one of those nice examples of what they say about dermatologists, that a dermatologist tells you in Latin what you just told them in English. Doctor, I've got these scaly bumps around the hair follicles of my skin. Oh, you have keratosis, scaly, pilaris, hair follicles. It's, and you get that here. It's very common. The skin will feel like sandpaper on the arm. It can be associated with redness. If you have a bad case, it can be on the thighs and back too, sometimes on the cheeks, and associated with some redness. And it's basically the common cold of dermatology. It's incredibly common, and I don't know that there's any great treatment for it. Because these places are rough and scaly, we often recommend moisturizers. One particular moisturizer, Lachydrin, or the over-the-counter version of it, amlactin, can be used. And dermatologists, I was taught that it probably works better than other moisturizers because it helps dissolve the scale better than just a moisturizer.
Oh, wow.
But my son had a pretty bad case of keratosis pilaris, and we were in Target one day, and I saw some amlactin. I was like, oh, let's grab some of this and use it. And oh, wait, there's some Lubriderm over there. Why don't we try this one too? And so he put the amlactin on one side and the Lubriderm on the other. And sadly, he told me he liked the Lubriderm side better than the amlactin side. So I don't know that there's anything to this idea that amlactin works better. I think using any moisturizer. One particular wife of a friend had it, and she swore by this apricot moisturizer she got from Bed and Bath and Body Works.
Everybody loves
Bath and Body Works. But I don't know. You could try different ones. There's so many good moisturizers out there. See if there's one that works for your keratosis pilaris if you have it. Staying away from harsh liquid soaps might not be a bad idea too. A bar of Dove is very mild, and it's probably a good choice.
Aloe vera, is that stuff good?
Not that I know of. I haven't seen any data that suggests it's any better than anything else. And I'd be worried that some people might develop an allergy to it.
Gotcha. What's the strangest skin condition you've ever come across?
That's hard to say because the skin is fascinating. The skin is our interface with the environment. The brain, the heart, the liver, the spleen, it's the same temperature, it's the same humidity. Everything is the same for those organs all the time. The skin, it changed. It feels different temperatures. It's exposed to different temperatures. It's exposed to injury. Nobody's doing this to your liver. hopefully, it's the ultraviolet light and all the organisms that are around us. It's fascinating. And so because it's the interface with the environment, all kinds of interesting things happen. Maybe one of the coolest is cutaneous larva migrans, or one of those dog with heartworms poops in the grass or on the beach. And you walk barefoot in the grass, or you sit down at the beach and put your hands palm down in the sand, thinking nothing of it. Now the heartworm enters your skin, but you're not a dog. The worm's looking for a dog. In a dog, it would enter the blood vessels and go into the heart and do its bad stuff. But because you're not a dog, you can't find any dog blood vessels. It just crawls around in your skin looking for the dog. And so you've got this, people come in with this intensely itchy, irregular track, maybe on their foot, on their palm. In training, I saw a picture of somebody who was a workman who crawled under a house and had an enormous number of these on the back. None of the other residents in my training program recognized what it was because usually you just get one track, but this person had them all over the back. But if you looked at any one area, you would see that it was a curly. I remember when it was my turn and they asked me, "What do you think this is?" And I said, "Cutaneous larva migrans." The other residents turned around and said to me, "Steve, cutaneous larva migrans doesn't look anything like that." And then the professor said, "That's exactly what this is."
Wow.
But yeah, I've seen a couple cases in my career, like 2, 3. It's not that common, but it's just awesome to see something like that. There's, you can get stuck by a rose bush and get a weird infection. There's some infections, similar looking infections from a fish tank where it gets in and then it'll create a series of lesions as it marches up towards your body over the course of months. Very slow growing infections. Zoster is another, I don't know, strange. It's very cool. It's more common. Shingles is another name for zoster.
Gotcha.
When you get chicken pox as a youth, it stays in your body the rest of your life. It hangs around in the nerves of your spine. The spinal nerves, you got one for one side, one for the other side. And if you get stressed or something and your immune system gets depressed, the chicken pox can come back, but it doesn't come back all over. It just comes back along the course of one nerve. And so you might get it on the tip of your nose and your scalp, or you might get it here or here, but not on the other side, just, like a band. Or along the chest, one band comes up to the middle and stops, might go down sort of the course of a nerve on the arm, and you get a series of blisters. It's a very fascinating condition. But, there's just so many strange things in dermatology. You can't count them all.
What about the shingles vaccine? Would you recommend that?
Gosh, yes. My gerontologist told me to take the shingles vaccine.
Good deal.
The old shingles vaccine was a live virus. The new one is a dead vaccine.
Huh.
And it's safe even for people who are on immunosuppressive therapies. If somebody's on anything that affects their immune system, it's even more important to go ahead and take that vaccine. Yeah. Maybe better to take it before they go on the immunosuppressive medicine, but if they're already on it, go ahead and take it. I think they're even recommending it for people who have had the older one, because the newer one, the dead vaccine, is even more effective than the old one. Now, I will say, I got mine at Publix, by the way. Publix, there was no line, just walked right up to the pharmacist there, and they had me sign my name on a sheet of paper, billed the insurer, gave me the shot right then. It's a 2-shot deal. I'm supposed to take the next one 2 months later, which it's coming up, but because of the virus, I may wait a little bit longer.
Yeah.
And then the other thing about it was the night I got it, I thought I was coming down with the flu. And then I realized, wait a minute, I had that vaccination this morning. That vaccination can make you have flu-like symptoms. So you may want to have some Tylenol already if you do go ahead and get that vaccine.
what's a common? Is there a common fungal infection that you see pretty frequently?
Yeah, the most common fungal infection I probably see is toenail fungus. Fancy
Oh,
name for that is onychomycosis. I
ugh.
think that's just something that people naturally get if they wear shoes, and uh, again, I see all the people who have it who come to me and are bothered by it. I don't tend to see, well, yeah, if I do exams on people, if people come in for skin checks for their moles and things, if I look at their toenails, there's a pretty good chance they'll have fungus there. The next most common thing is athlete's foot with fungus either between the fourth and fifth toe or
Yeah.
on the bottom of the foot. Less common is fungus in other areas, but you can get it in the scalp. I've seen it on the face. Sometimes that's a little tricky. We're not used to seeing on the face, and somehow I think we're not tuned into it so much. And you can see it on the body. One of my favorite things is when a mom brings like 4 kids to see me. I will open the door of the room and there's 4 kids without their shirts on. And maybe I see a little bit of a red circle on one of them. And I'm like, hey, you guys must have gotten a new pet. Was it from the pound? Was it a kitten or a puppy? And they'll say, we got a puppy. And you know this because they've all got ringworm from hugging the puppy. And they've got the rings on their forearms, inner aspect of the arms, and the upper chest where they're hugging the animal. People with diabetes, they're at higher risk of getting fungus infection. So they may have it on the foot and maybe it spreads all over them. If they go to their family doctor and the family doctor is not sure what it is and gives them a steroid, the fungus can spread even more because the fungus just loves the steroid.
Oh, no.
The steroid turns off the body's immune system, so the fungus goes even more wild.
Like
And this is one of the reasons dermatologists think family doctors don't know what the heck they're doing. But again, we only see the ones that they didn't get right. We don't see all the ones that they cured. So they may be doing, I'm sure they're doing a fine job.
wow. So just common like hydrocortisone that could actually inflame fungal infections, huh?
Yeah, absolutely.
Wow.
Hydrocortisone is great for inflammatory things. So if you get a bug bite and you're itchy, yeah, good choice. Poison ivy, good choice. It might not work. You might need a stronger one. You could talk to a doctor about that, but you could start with hydrocortisone. Eczema, that might respond to over-the-counter hydrocortisone. But infections, no, you don't want to mess with hydrocortisone with infections.
Now, ringworm isn't actually a worm, though. It's a fungus, right?
Ringworm is fungus. Yes, exactly. And they call it ringworm, I think, well, because it can cause rings. Doesn't cause rings between the toes there. It's just red and scaly. But on the body, it's common for it to form these rings. I think you get the fungus in a spot and then it gradually spreads out and you get that ring at the edges.
Is it like a bullseye rash from Lyme disease, or is it?
Oh, that's a really great question. Tends not to be. It tends to be a ring with complete clearing in the middle. And the ring tends to be a very narrow ring. It's like a string. And it's red and scaly. My impression of the Lyme rash is it's more like a target. Like you say, the ring is a wider ring. And maybe there'll be red, white, red, target shaped thing, and gradually spreading. It won't be scaly. And it tends not to be raised, if I'm not mistaken.
Oh, so
it's in fact, the name for it, the fancy name for it is what is it? Erythema centrifugum.
erythema migrans?
Erythema migrans. Erythema migrans. So erythema, again, this is just a dermatologist telling you in Latin what you told him in English. Doctor, I have a red rash that's spreading. Oh, you have erythema migrans. Where erythema means redness, migrans means spreading. So, yeah, and because we call it an erythema, that means a redness. It's not raised, it's not scaly, it's just a redness.
Gotcha. Erythema. And it's the bullseye has the concentric rings, and it's often.
There can be fungus that has concentric rings. I think it must be pretty uncommon, at least in the United States. I haven't seen many, if any, cases.
So many things going on with the skin. It's really
yes, absolutely. When you think about how complex the skin is, you've got a dead scaly layer on the surface. You could have abnormalities of that. You have living layer underneath that. You can have abnormalities of it. It's held to the underlying layer with fibers that your body can make an immune response against, causing blistering. Then you've got blood vessels and the cells that make the collagen. You've got the collagen, and you have basically the most important immune organ in your body is the skin, because it's what fights off all the infection. And so you have problems with all of these things.
Now, a recurrent infection, or something that's recurring in the news more and more often, the health agencies are starting to sound the alarm about the resurgence of syphilis, which does cause or can cause serious damage to the skin, if I'm not mistaken. Are you seeing more cases of syphilis in your practice, and how can it impact the skin?
Yeah, I have not seen cases of syphilis in years. There might have been one that somebody in our department saw. I think they're getting screened out by family doctors, infectious disease specialists, public health practices. I haven't seen the syphilis, at least not that I've recognized. Maybe it came in and I didn't realize it. But it can start as a genital ulcer, and I haven't seen any of those. And then the ulcer may clear up, but then the syphilis spreads all over the body, causing a scaly red rash all over, which would be even more typical for a dermatologist to see. Distinguishing it from psoriasis maybe sometimes can be a little more difficult, but they say that the syphilis would involve the palms and inside the mouth typically. And then that can clear up, and if you don't treat it, it can go into the brain and cause neurosyphilis and horrible things there.
Yeah. In the same class as the great imitators, so it may be hard to distinguish sometimes, especially in the later stages.
Yeah. Well, one of the fascinating things about the skin is that when these things go away, the skin can go back to normal. You can have this horrible psoriasis, and you treat it, and the skin goes back to normal skin, no scar. I think one reason I'm a dermatologist is because I was so intensely to poison ivy as a youth. The cases of poison ivy I had when I was a kid was worse than anything I've ever seen in like 30 years of dermatology practice. And the skin went completely back to normal. Eczema clears up, goes back to normal. Syphilis, the rash clears up, goes back to normal. Yeah. Skin's an amazing organ.
A lot of genetic information in there, huh?
It is fascinating, yeah.
Well, now you're up there in North Carolina, right?
That's right.
And I'm down here in South Carolina, which makes us part of the Southeast. What's a skin condition that's common to Southerners that people from the South should look out for?
Well, fair Southerners like you, it would be skin cancers and precancerous lesions.
Yeah.
There's melanomas. Those are horrible. They're cancers of the pigment cells in the skin. Oh. If you have a mole that's irregular in shape, growing, changing, large, irregular in color, not sharp borders, those are signs of melanoma. You want to get that seen right away and get that removed. The other form of skin cancers that are much more common than melanoma, but much less aggressive, would be basal cells and squamous cells. The squamous cells may start as just red, scaly precancerous lesions, little scaly rough spots that are red on the sun-exposed areas like the forearm, back of the hands, and face. And if you're losing your hair and not wearing a hat, on your scalp. So I'd wear a big hat down here in North or South Carolina. Psoriasis, because it gets better with the sun, is probably less common down here. You guys down in South Carolina, I don't know, there's something about the border between North and South Carolina where it gets a whole lot more humid when you cross that border. I did a year of my skin pathology training in Charleston, and it was hot in North Carolina when we packed the car and we got to South Carolina, and I had no idea what hot was. I mean, we got there at midnight and it was hotter and more humid than anything I'd ever experienced in my life. Not to mention the palmetto bugs and the no-see-ums coming through the screens. So I think where you are, fungus on your feet would be really common.
Well, palmetto bug is just a fancy way of saying cockroach, but
Gosh, yes, they're horrible. Oh my
I
God.
don't know. The cicadas down here are giving them a run for their money, but um, no, North Carolina is very nice, especially Hendersonville and Asheville is particularly pleasant to visit. So definitely stay out of the sun. Get your sombrero, and what about SPF lotions?
Yeah, they're very good if you want to take the time and trouble to do it. I think it's, a safer bet to join the Amish faith. Let them give you a really big hat,
Yeah.
maybe, a straw one that's tightly woven for the summer so the light doesn't come through,
Oh, I
and
get it.
use that and be religious about putting the hat on. But if you like the idea of doing sunscreen, sure, the higher the number, the better. Basically, the reason higher the number, the better is because the number is sort of like a denominator. So, for example, if you're going to be out in the sun for 60 minutes, you get 60 minutes of sun. If you're out in the sun with an SPF 2 on your skin, then it's 60 divided by 2. So you're only getting 30 minutes of sun.
Oh.
If you're wearing a 15, you're only getting 4 minutes of sun in that hour. If you're wearing a 30, you're only getting 2 minutes. If you're wearing a 60, you're only getting 1 minute. That's why some people think, well, 15 or higher is pretty good, because what's the difference between 1 minute and 4 minutes? May not make much of a difference. But if somebody's super fair, maybe those higher numbers are better. And the other thing is, those numbers are dependent on using the standard thickness. And if you're using less than the standard thickness, your 60 might only be a 30 or might only be a 15.
Oh, well, just depending on the spread, how thick you spread it
Yeah,
out.
the thicker the spread, the better it blocks the light.
Wow. Huh. And so sunlight exposure is kind of like it's radiation. I mean, so it's all about exposure time.
Yes, I mean, it's, lying out in the sun is like, I'm going to go visit Chernobyl and lie out next to the nuclear reactor. And you got the giant fusion reactor in the sky, and it's irradiating us. Do you really want that? Well, it turns out some aspects of it may not be so bad, but I wouldn't want it on my face. When I was young, I did stupid stuff. I skipped so many medical school classes to work on my tan,
Yeah.
Now I wear a hat, keep the sun off my face, try to keep my youthful glow as best I can.
Okay, we just got CBD all over the South. And it's in everything from shampoo to skin moisturizers. Any scientific evidence it's doing anything?
Not that I'm aware of. It's such a great, fascinating topic. I think, with so many people being out of work right now because of a COVID infection, if I were in charge, the first thing I would do would be legalize marijuana.
Wow.
It would improve the economy. You could tax it. People could have jobs growing it. And, with so much stress in our lives from the infection now, maybe this staying at home would be easier, Not that I know anything about that. There are in the skin receptors for cannabinoids. What they're doing there, I don't know. They may have some relationship to itch and things. And what happens when you turn them on and whether CBD oil will turn them on or not, I don't know. It's a very active research in science.
Right.
And so right now, my feeling is if you want to try something, great, see how it does. Me being the scientist, I would say try it on one arm and not the other and see if you can tell a difference. But I can't like recommend it as a treatment for anything at this point. I don't have the data to do it.
Gotcha. Yeah, go slow if you're going to try it. And but there are receptors in there for those cannabinoids. Fascinating. All right. So on the flip side, what about amphetamine prescription medications? Are there common concerns of being on those? And is there a time when they should look at considering coming off of them?
That's a great question. So I don't know of any skin disease that we're treating with amphetamines. So this is not an area that I have a lot of expertise in. I would say, whoever is your physician, I would want to be on as little amphetamine as possible. Now, my perception of amphetamines is colored by selection bias. When I see patients for a skin problem that's related to amphetamines, it's always something bad that the amphetamine has done. It's not something that the amphetamine has made better. And this is like the one area where there may be some relationship to Morgellons disease, because amphetamines can make you feel like there's bugs in your skin. And so some of the people who I see who have delusions of bugs in their skin are on amphetamines. And it certainly seems like their amphetamines are related to their perceptions that there's bugs in their skin. Morgellons may be something entirely different. Right now, I'm talking about the people who are delusional and who there's no bugs in their skin and they think there's bugs in their skin. They think there's this worm that's in their abdomen and it's making larvae, and the larvae are coming out of their skin and they're coming out of their eyes and they're picking the stuff out and they're showing you bits of dirt and stuff, and they're convinced that it's these bugs crawling in their skin, and you get them off their amphetamines and they get better. I mean, we know amphetamines can do that to people. So that's my experience of amphetamines as a dermatologist. I have no other experience with amphetamines other than there's a lot of people on these ADHD drugs, which are amphetamines. And many of them are on it. It's on their med list, but they're here for acne or something. Okay, fine. But the only time I see those ADHD drugs associated with a problem is when it's associated with a problem. Like delusion.
Now, and a delusion is when somebody believes something that is contrary to the evidence. Like, for example, somebody with an infestation, that can be elicited. You can give them a test that can say, oh, yeah, you've got that worm in your body. But the person who's delusional, you'll do the test, say, hey, there's no worm there. But they'll say, oh, I don't believe that. That's a government conspiracy. Something in them doesn't want them to accept that information. And it's okay for people to be skeptical. But when the evidence is insurmountable, then it's time to reassess your position. And that delusional state can be detrimental to their way of life, right? They can actually be so embroiled in the delusion that they're not going anywhere.
Yeah. You know, one reason I find this area so fascinating is because of my interest in human perception, how people perceive me as a doctor and its effect on their adherence, how they perceive their medicines. And a delusion is, I mean, these people, the delusional patients, know there's a worm. Their brain senses it. Whatever the neural pathways are, if you had a worm, they're firing. And so inside their head, there is this worm in the skin. And there is no evidence that's going to change that. Okay. You can give them all the evidence, but their brain is perceiving the worm that's there. The amphetamines perhaps are driving the neural pathways, causing, and it's not, you know, one of the things I use to illustrate this with my students is the color of my vein. I don't know if you can see it there. Can you see my vein? It's kind of a blue color. I don't know if you can see it, but if you look at your own vein, you'll see that it's blue. And Jeremy, you know why your vein is blue?
No.
You know about the hemoglobin and if you heard about the deoxygenated hemoglobin?
Yeah, your blood is blue until it hits the oxygen. Is that right?
That's what everybody says. Okay.
Right.
All the medical students say it's the deoxygenated hemoglobin. I give blood at the Red Cross every 2 months. Your listeners should too, probably. Every time they stick a needle in my vein and take the deoxygenated blood out,
It's
red
red.
stuff comes out of my arm, not blue stuff. All these medical students, they tell me it's the deoxygenated hemoglobin is why it's blue. I said, have you ever taken blood? They say, yeah. What color came out? Red. Why are you telling me it's the blue stuff? There's nothing blue there. It can't be blue. It's all an optical illusion. If you put 2 business cards or 2 pieces of duct tape on either side of the vein, you'll see it's pink. Now, it's a bluer shade of pink than the surrounding skin, but your brain interprets it as blue.
Nice.
Okay? Now, you know the vein can't be blue because you know the blood is red, right? You understand now that it's an optical illusion. Look at your wrist. What color do you see?
It's kind of white.
You don't see blue.
I see that blue thing going right through the center.
You see the blue things. So you know it's not blue, but it still looks blue. When these people have a delusion, whether it's due to amphetamines or due to psychiatric illness, they see the worms. Okay? I can give you all the evidence in the world that this isn't blue. It still looks blue. To the brain, I don't think I can convince these people that there are no worms there. I just don't think it can be done. Dermatologists, some dermatologists believe you can't buy into their delusion. You have to tell them it's not real, you know, and maybe that works for some people, but I only see the ones in whom that doesn't work for. They've seen other dermatologists. They come to see me with their delusions, and I will explain to them if it's a delusion due to what I think is the amphetamines. The amphetamines has made you a petri dish for this, which is true. Now, they're interpreting it as it's made them a petri dish for the worms. I didn't say that. I just said it's made you a petri dish for this. What is this? Could be different between what they're saying. I can't lie to a patient, but I can mislead them. I think that's kosher as long as I'm doing it for their benefit. And so I tell them the amphetamine's making you a petri dish for this. We have to cut the amphetamine level down.
So, and that's what I was fascinated by was taking them off amphetamines. Does it typically, always, or sometimes result in alleviation of their delusional state?
I don't know. It's such a rare thing. I've seen a few cases, and I don't know that I've seen many who actually reduce their amphetamines because people are addicted to these amphetamines. I don't think people who are not addicted to the amphetamines get delusions from them. And maybe I'm wrong. Maybe they could. But I think it's probably the people who are really pushing the dose and taking too much. And
like everything, it's nuanced. But to summarize, basically, majority of people who are prescribed them are able to take them fine with no problems. And but there is a perceived or perception that in some patients it may lead to a delusional state, and it's not right for them to be on it.
I think that's probably right. And I would encourage you to, bring on a family physician and or psychiatrist who specializes in that area and prescribes a lot of it, because I don't prescribe it. I don't know what the right dose is. I don't know anything about tapering it down. I don't want people to stop it too fast because I'm afraid what the side effects might be of stopping too quickly. And it's an issue that goes certainly beyond my expertise in some ways.
Gotcha. Yes, sir. And there's even some research that shows that coffee and stress will lead to delusional states. So,
yeah, I am so clean. I'm not even on caffeine. I'm a caffeine-free Diet Coke drinker.
Wow.
One bottle of soda keep me up all night. It's a powerful drug.
Dr. Feldman, have you ever had a bad experience with a patient? Have you ever felt endangered?
Not so much that it just jumps out at me as, oh, I remember this one time when I finished medical school, I did 6 months of psychiatry residency, not because I wanted to be a psychiatrist, but because I thought it would be good for somebody like me to have that experience, a good way to transition from not being responsible as a medical student to being responsible as the physician And so I did 6 months of psychiatry before I did my medicine in dermatology. And in psychiatry, you would be coming to the emergency room and seeing people who were strung out on drugs or who were acutely suicidal or acutely homicidal. And I think there were times then where one of the first things they taught us in psychiatry was always position yourself between the patient and the door so that you can get out if you need to.
Oh, wow. That's some good advice. And that's a small room.
Yeah.
Well, I'm glad nothing jumps out.
Yeah. Maybe the most endangered I would feel right now is if I was seeing a patient for psoriasis or acne and they coughed.
Oh, yeah. Well, that would be scary right now.
It would. Right now, it's a really terrifying time. Maybe when AIDS was first coming out, it was terrifying drawing blood on people because you really didn't know and what was before they even knew what the virus was that caused it and stuff. That was when I was in medical school, and that was a scary time. So right now, I go to work and I'm putting a mask on. I would think patients should be putting masks on. It doesn't have to be a fancy mask. Could just be a piece of cloth, a scarf, anything probably reduces spread, I imagine.
Yeah, that's the key, is that it's not necessarily to keep you from getting infected, but nobody really knows who is infected, and it prevents anybody else from catching your spray.
Yeah, I think we should all have a mask on. Now, there's no one else in the room with me now, so I think we're okay.
Emotional stress. Is that going to mess my skin up?
Yeah.
How does that work?
So the scientists who are interested in this, I think, believe that there's a mind-body connection mediated by the immune system, that the brain is affecting the adrenal gland and the spleen and affects the immune system and things like that. And maybe there is. But to me, everything revolves around getting people to use their medicine. And I'm pretty sure when you're under stress, you don't use the medicine as well.
No.
And so when they say stress causes psoriasis to flare up, or depression causes psoriasis to flare up or be more resistant to treatment, I have no doubt that it's true. I just don't think that it's a mind immune system connection. I think it's a mind treatment connection, that people are pretty non-adherent to their treatment normally. And when they're really depressed and they're just sitting there like this.
Yeah.
I really don't think those people have the motivation, the energy to put their creams on. I just don't think it's possible. So I think there is a connection between stress and many diseases, but I think we have to seriously think of first adherence to treatment, because changes in adherence to treatment can be very large and can have enormous effects, whereas these other effects of between stress and the immune system, I think, are pretty small. Now, right now, I would try to stay calm, because I do think stress makes people more sensitive to getting viruses and stuff. And so I would stay calm, get some regular exercise, take some yoga, It's a good time to keep the stress level down.
Good deal. Good deal. Yeah, and when they're stressed out, they may skip out on meals even.
Yes, and again, that could affect your immune system. So there could be an effect that mediated by your diet as well.
Exercise. What about the cracked heel? That'll keep you from walking around the block.
Yes, a cracked heel. Dry cracks in the heel, I was taught when I was a resident, is a major issue for women, because it tears nylon stockings. Now, I don't know if anybody's still wearing nylon stockings, but 30 years ago when I was in training, that wasn't uncommon. And so, yeah, using a moisturizer on the heel was probably a good thing. And there's a number of moisturizers that contain either urea or salicylic acid, which helps dissolve the thick, dead, scaly layer of the skin. And so those moisturizers, I think, are the particularly good ones. So that amlactin I mentioned might be one that has lactic acid in it. It's good. Keralite has salicylic acid in it. And then one of my partners really loves prescribing the Neutrogena foot cream that has, I think, a high concentration of urea in it.
Yeah.
And he thinks those are particularly good ones. And I have no financial interest in any of those three companies.
Full disclosure. Is there any surefire way to distinguish between a laceration, which is basically like a cut or a scratch in the skin, and an ulceration, where the lesion begins from the inside and then opens out?
So I'm not sure that's how I would define ulceration. I could be wrong, but laceration to me means a cut, which is going to be linear, typically a line, whereas an ulcer would tend to be, well, it's not always round, but and I guess you could have linear ulcers, but it's not a cut. It's an open wound, and they tend to be more round, but you could have an ulcer from, let's see, what are common forms of ulcers? You get ulcers like leg ulcers from having poor circulation around your ankles. You can get ulcers. Those tend to be round ulcers. You get pressure sore ulcers if you're laid up in bed or a wheelchair and don't move. Those can be ulcerations. They don't come from the inside, probably. I think they're coming from destruction. A burn can cause an ulcer from the outside inward.
I gotcha.
So how would you distinguish the laceration? But a laceration to me means a cut, and it tends to, I mean, I think that's just the definition of cut. It's a cut, and you either had a cut or you didn't. And you probably, if you had a cut, if it's small enough, you ignore it. Maybe close it with a piece of tape, medical tape maybe, or sew it together. Whereas an ulcer, I don't think of that as something you would try to close typically. You try to get it to heal in. Yeah.
From my listener's perspective or viewer's perspective, it's kind of a struggle to work with doctors when patients are going in. They know that they didn't cause a wound on their arm; it just opened up, and the doctor may mistake that as a scratch. Say, "Well, you scratched that into your arm," and so what we're looking for is the best way to be able to communicate that to the doctor, and so that it's responsibly resolved. And so the doctor understands that, okay, this happened, but not this happened. How can the doctor determine that? And because without taking the patient's word for it, I guess is what I'm asking.
Yes. So without taking the patient's word for it, how would you distinguish something? Well, it would be, I think, very hard to induce a perfectly round ulcer.
No.
So a perfectly round ulcer would be less likely, unless it came from a cigarette wound or something. But I mean, if it wasn't the size of a cigarette or a cigar or something, if it has the width of a nail and it's not round, but kind of nail shaped at the top, lines down the side, and then nail shaped at the bottom, like it got dug, it'd be hard to convince the dermatologist that it wasn't something that was dug. And the dermatologist might even wonder, you may not know you're doing it to yourself. You might be doing it in your sleep. Who knows? There are people who have itching disorders, like people with kidney disease.
Yeah.
And they have terrible itching. They may be on dialysis, and they may dig out a spot, and they may say, "Oh, I didn't do this to myself," when in fact they actually did, and they may not realize it. So they don't even know that they're scratchy. They didn't do it on purpose to themselves. Their subconscious brain sent a signal to their other hand to do the scratching without them thinking about it. But having, if we get into the more Morgellons question, and there are those people who are delusional, and then there's those people who have these sores, and we don't know what's causing the sores. And It could be that there's staph infection in the skin, down in the hair follicles, causing ulcerations to form, for which antibiotics may or may not be particularly helpful. There may be some underlying inflammatory disease that's causing ulcerations due to the inflammation attacking the skin and such. I don't think Lyme causes any kind of ulcerative disease of the skin, but maybe there is in some subpopulation. How you deal with that when medical science doesn't know what's causing it is, a real issue. I think if a patient tells me, I know it's coming from Lyme disease, when I can't tell from science what's causing it, I think that tends to create conflicts and issues for me. But because it sort of seems a little like a delusion, but this is a different kind of delusion, because there's the amphetamine delusion where your brain, like the vein is blue, knows there's this worm in there. And then there's people who've read about Lyme and who are logically thinking that it's Lyme disease causing their problem. That's not really a delusion, but it may sound like one to a dermatologist who has looked at the evidence and doesn't see it the same way.
Right.
I'm going to just grab a power cord real quick to make sure. I should have done this before, just to make sure I don't lose you here. Sorry about that.
That's okay. We're getting ready to get into the last couple of questions, but these are really good ones. And I wanted to tell you, I started having the sores years and years and years before I even heard of Morgellons. And I did confirm, my doctor also confirmed with microscopy that the fibers are present, and she recorded those. But it wasn't ever the fibers that were bothering me. It was always the sores, the disfiguration of my skin. So, but before I had a chance to see my doctor, who does understand Morgellons, I did see a dermatologist who did ask me, in the emergency room, what I was doing to do this to myself. And, I took offense to that. In retrospect, I see now that he just didn't have the information. Nobody had the information back then about what was going on. And he was just making the best educated decision when he was there. So it's a different kind of world today than it was 10 years ago for Morgellons patients, or even 15 years ago when I was talking about seeing the dermatologist in the emergency room. But what about your current perspective on Morgellons? Has it progressed? How do you feel about the legitimacy of the condition today?
Well, yeah, I don't know that it is a condition in the sense of one thing. There's those people who have delusions, who are either psychiatrically ill or because of substance abuse. They think there's something, some horrible worm crawling around that isn't there. That, I think, gets lumped in with this other form of sores that are occurring, and medical science doesn't have the answer yet why they're there. I'm pretty sure it's not Lyme, but what it is, I don't know. You see staph infections get down into hair follicles and cause sores.
Yeah.
Is it possible that some people have a sensitivity to certain bacteria that other people aren't sensitive to? So when you culture and you don't find pathogenic staph, you say, well, it's not staph infection, but it actually is. And it's just that this person reacts to that staph differently than somebody else does. Oh. So I think I don't think the fibers have any meaning whatsoever. I think there's fibers in my clothing. If you look at fibers, if you look at the people who believe that these fibers are a manifestation of Lyme disease, and you look at their research, what do they find the fibers are made out of? They're made out of things like keratin. And what is keratin? Keratin is the hair protein. And so their conclusion, because they're focused on it being related to Lyme, is that somehow the body is making these hair filaments somehow, when I'm like, well, wool is sheep hair? And are the fibers just a little bit of wool that got drawn into the skin? The idea that the body is making red, blue, and white fibers makes no sense to the chemist, physicist, scientist in me. It doesn't make any sense to me at all. But having some red, blue, or white wool get stuck into a skin lesion makes perfect sense to me.
Sure.
No one has shown me a biopsy of how, from a Morgellons patient, showing where these fibers are being made by the body. It's just, it makes no medical sense to me. Other stuff, I had the unique pleasure among dermatologists of getting to go to one of the Morgellons annual meetings. And I remember going to the guy selling vitamins, and he had these beautiful graphs showing that these vitamins can block the growth of the Lyme organism.
Oh.
But if you were a scientist like me, you pay attention to things like the concentration that they were putting in the tubes. And the concentration meant you would have to eat your entire body weight of the vitamin right away and not pee it out as fast as you took it in order to achieve the concentrations needed to affect the bacterium. It made no sense at all, but they were hawking these things to people. So I don't know if that answers your question. Maybe it answered a small part of your question.
It gave me more information. And I do have some recent research that I'd like to share with you in an email later. That may or may not change your perspective on it. I do understand where you're coming from, particularly in regards to the fibers. So yeah, that does answer my question, and I definitely appreciate your perspective. What about speaking at the Morgellons conference? Was that challenging?
I don't know. I mean, well, I'm a nerdy test tube scientist. I'm a little autistic. It's easy for me to go into this meeting much as it to a dermatology meeting, because I don't have a warm, fuzzy interaction with other people. I'm like in my own world. And, I think other dermatologists probably never would have gone. But if they had gone, they'd have been much more uncomfortable than I would have been. Because other people's anger probably doesn't affect me maybe as much as it affects other folks. The initial plan was pretty straightforward. I started this doctor rating website. I've done research on patient satisfaction. I thought I had some useful information to share about how people can have a better visit with their doctor. And so that was the title of my talk and the topic of my lecture. But right before I gave my talk, Pi Ware, who is the producer and director of the Morgellons movie, Skin Deep, got on, gave a talk first. And he showed a trailer from the movie where I was talking about the delusional patients.
Oh, the setup.
Yeah. So I don't know if the expression "throw a person under the bus," and this is Texas where people carry weapons, so I got up and gave my talk, but I don't think anybody, I can't say anyway. I don't think anybody was really listening to my talk. Nobody had any questions about how to have a better visit with the doctor.
Yeah.
Their point of view was it shouldn't be my job to have a better visit with the doctor. It should be the doctor's job to have a better visit with me. And they're right. If I was lecturing to doctors, I would give a lecture on how doctors should behave differently. Because if the lettuce is not growing well, you don't blame the lettuce,
right.
But the patient shouldn't be blaming the lettuce either. The patient can't control the doctor. The patient can only control what they do. So it doesn't hurt to go into the visit with the best strategy for having a good visit. Clearly, you're already thinking about this. how can I communicate to the doctor that I'm not doing this? So you're thinking, what can I do to make a better relationship with my doctor? And
Correct.
so that was what I was trying to get across. But I think the movie director poisoned any opportunity to have that conversation for me. And so people were focused, I think, I don't know if it's in the movie or not, but after my talk, after there's this discussion, Ginger Savely got up, and I think she was trying to be nice and make things better for me, but she was echoing this idea that I should really be talking about what the doctors can do to do better. I'm like, no, not to a group of patients, to a group of doctors. Sure, I will give that talk to the doctors, but to the patients, you need to know what you can do to have a better visit.
Well, in regards to Morgellons in particular, whether you have it or not, neither the doctors nor the patients have definitive answers for this.
I agree. I agree completely.
So,
and I think to the extent that patients think they have the definitive answer, that's one of the times that causes the doctor to think they're delusional.
right.
Now, they may think they have the definitive answer because of research that they've done, which to me is not a delusion. And so there's this gray area where the doctor's thinking one thing, patient's thinking something else, and there's a miscommunication going on.
That's an opportunity for a pleasant visit.
Can be, I hope. Yeah.
We can unlock the key. This is it, my friend. I appreciate you making time to be here with us and to educate us more about common skin conditions. You definitely are a accomplished professional in your field. And the things that you're doing with www.doctor, that's drscore.com, are really exciting. What is in the future for Dr. Feldman?
Well, hope I can be on again. If your listeners have questions they send to you and you want to have me back, I'd be glad to do that.
Sure.
I'm going to be spending a lot of time at home doing a lot of hand washing until this virus is gone. Trying to do my research on how patients can use medicines better. And I'm trying to do that without actually seeing patients. There's more teledermatology going on in my life right now.
That's some good stuff. That's a good opportunity. Yeah. Where can people go if they want to reach out to you?
So to reach out to me directly, my email address is sfeldman@wakehealth.edu. My cell phone's 336-577-1164. You can send me mail. My professional address would be Steve Feldman or Dr. Steve Feldman, Wake Forest School of Medicine, 4618 Country Club Boulevard, I think it is, Winston-Salem, North Carolina, 27104. If you just want more information, if it's about psoriasis, the National Psoriasis Foundation is an incredibly great organization.
Oh.
It's their website's really easy, psoriasis.org. And general information on other skin conditions, the American Academy of Dermatology has some resources. There's a great website that the dermatologist in New Zealand has put together. And so if you're interested in any skin condition, you put in the name of that condition and the word New Zealand after it, and it'll take you to a great website.
Oh, cool. Very cool. Dr. Feldman, thank you again for making time to be with us today. I definitely hope to have you back on the show, and I had a great time today. Thank you.
Yeah, it's been my pleasure. Thanks, Jeremy.